two psychiatrists rapping about our lives and work.
This podcast is not intended to be medical advice. Any stories we use have been altered to protect identities and sensitive information.
This is intended for entertainment purposes only.
You know it!
Ow!
Welcome back to the Good Strings podcast.
Glad to have you here.
Yeah.
We're going to talk about some things that are near and dear to our hearts.
Something that we use every day.
Every single day.
In fact, it defines us as psychiatrists, right, T?
Right. Medications.
That's right.
You know, it's a tool that we use. You know, we have lots of tools in our toolbox to help the patients that we see, and medications are a big part of that.
Yeah.
It's what we use to try to control some of the more severe symptoms, you know, that we see in the emergency room. For lots of different disorders, we see people with schizophrenia that we might use antipsychotics for. We see people with bipolar disorder that might need mood stabilizers. So there's lots of different categories. And one of the things that we're going to dive in today is antidepressants.
Yeah. T, I don't know if you know this, but do you know where antidepressants sort of originated from?
Where'd they come from?
So apparently back in like the early 1900s, Ipronizid was a TB medication for tuberculosis, which did not work very well.
For TB.
For TB. So they were struggling with TB, but they became less depressed.
I was about to say, I'm so happy I have TB now. The sun is shining.
Yeah, it's like, I've never felt better. I'm going to go run a marathon.
It's so interesting how there are so many medications that we use just across the board that actually had an initial indication that didn't work out, and then they sort of serendipitously found that they were effective for other things. Yeah.
Yeah. And unfortunately, I think it was pretty hepatotoxic, like it really affected your liver, so they stopped using it like in the mid-1900s, but it had antidepressant properties. And
it gave them a place to start to look at what was different about this medicine.
Yeah, and I almost wonder, like, were they getting a little manic maybe?
Maybe.
But they found like it did improve their mood, and that's kind of where antidepressants derive from. So it was actually from sort of an unfunctional antibiotic, which is interesting.
Yeah. So, you know, antidepressants in general, you know, there are different categories. We see people who come in with different degrees of depression. Some people might just have an adjustment disorder, so they're just kind of going through a stressful time. They may not meet full criteria for a major depression, but they're having trouble sleeping or they're having trouble with their appetite. And so we might try an antidepressant to help give them a little bit more energy or to help them sleep better. So often, I don't know about you, C, but I will look at what the main symptoms are that a person is coming in for and then try to tailor the medication, sometimes using the potential side effects that some of the medicines have, to give them a better, you know, response to the medications or function better.
Yeah, I agree. I think sometimes the side effects from the medications or comorbid issues that the patient is having really kind of dictates what antidepressant we use, you know?
Absolutely.
You know, for you, T, like, do you have certain antidepressants that you favor that you just like, you tend to use a little bit more often?
Yeah, and you know, I wonder if it has to do with my time in residency, because I think, you know, some of the newer residents probably have more experience working with these newer agents, but my rule of thumb was to never really try something that hadn't been on the market for at least a year.
Yeah.
Because you want to read the reports to make sure that these things are safe. But so some of the things that I use are, you know, kind of just following some of the guidelines for treatment for depression. I usually start with SSRIs.
Yeah. The first SSRI was developed, I think, in 1988. Prozac. Right? Prozac Nation. It like changed kind of the way we prescribe medications. And really they're the safest, right? So they really did kind of escalate in use, because if you think about, we're giving these medications to individuals who sometimes say they're going to hurt themselves. So you don't really want to prescribe them something that they could potentially harm themselves with.
Because some of the older antidepressants, there were antidepressants before Prozac, but those medicines were effective, you know, the studies showed, but they had really potential lethality with people who would overdose on them, things like tricyclic antidepressants and things like Nardil and Pamelor. You may recognize some of those names. And they are still used actually for other things besides depression, like trigeminal neuralgia or, different neurological conditions, because it sort of helps with the nerve problem and also causes sedation. So these medicines usually are given at night and people, can sleep, which a lot of people with depression are having trouble sleeping. So they were effective in that way. But medicines like Prozac were developed to reduce the lethality risk in antidepressants because, suicidal ideation is unfortunately, highly associated with depression. And so these people are depressed. They feel like they want to hurt themselves, and then you've given them something that they can use to do that with.
Sort of, against themselves in a way. And
so there was an incentive to make safer antidepressants.
Yeah, and really, like, going back to the tricyclics, like, the only time I really see them used now is really for a couple of reasons, like either migraines with insomnia or a lot of GI doctors, gastroenterologists, they tend to use it for like IBS, I've noticed. But really, other than that, like, we don't use them a ton anymore. And kind of like you mentioned, if you were to overdose on like a tricyclic, right, there is a risk you could develop like a heart arrhythmia. I believe it was Torsades is a main concern, and so they just
and respiratory depression.
Yeah,
I mean, it's basically just
they had more side effects.
Breathing. Yeah,
like, I think there was even like orthostatic hypotension and other things. So then once SSRIs came around, it was considered like a cleaner medication, and they really kind of took off in popularity. And now, they look at studies about depression, and everything comes down to like the economy, right? And how much depression can affect the economy. So one of the more recent studies I saw, it mentioned like there's like $35 billion in economic loss a year due to depression. Actually,
it's a big problem.
Yeah, it's probably even higher now. So if you think about it, that's 35 Taylor Swifts.
It all comes back to Taylor Swift.
Right? Think about that's kind of interesting, right? Like, just 35?
Yeah, so what about you? Do you have any favorite? So what do you do if, let's say, we use antidepressants like Prozac, SSRI, if that's our first line, and it doesn't work? What do you usually do?
Yeah, so, first line, if I use something like Prozac and it's ineffective, you really kind of have two options. Either consider another SSRI or adjunct with something else. Typically, Prozac I like because it has a long half-life. It can self-taper if the person's not very consistent with the medication. And it is a little bit activating. There's a little bit of norepinephrine and even a little bit of dopamine elevation as well. But I'll be honest, for me, I'm like a sertraline guy. I just love Zoloft. I think, I don't know, just anecdotally, like patients I see, if they don't respond well to like Prozac or Lexapro, it's like there's something about Zoloft that like takes off the anxiety edge.
Interesting.
And it just seems like, just from my experience, I just feel like it works a little bit better. It's completely just my biased opinion, but
I'm using a lot more Lexapro too, especially in kids. It's like one of I think Prozac and Lexapro, the only really FDA approved, medications in children for depression and anxiety. And so one of those two is kind of what I go to for my kid population to start with. And obviously, I mean, not obviously, but often when children come to the emergency room, that's their first time, seeing anybody. So usually those, and they're safer than other medications. So those are the ones that I usually go to. And I talk to people about these medications. Sometimes people take antidepressants and think, I only need to take it for as long as I'm depressed. And these medicines are designed to build up in your system and then to push into what we call this blood-brain barrier, which is this like little partition over your brain, protects your brain. And medicines have to get to a certain concentration to push past it and then to get into your brain and do all we want it to do. So that takes a little bit of time. So it can take 4 to 6 weeks to get to that concentration, and that's if we're at the right dose. So we might need to adjust the dose over time. So you're really committing, once you take one of these medications, you're committing to some time on it. And I also tell people, after you do achieve a response, you really should be looking at 6 months to a year on that medication. After which time you and your doctor can decide if you're doing well and you're stable, you might be able to come off of it. And then you may never have another episode. If you do have another episode, then I think you're looking at probably 5 years to the rest of your life on the medication, depending on how severe your symptoms are when they come back. So it's just kind of a guideline.
Yeah, I've heard very similar. Like if you've had a, let's say third relapse into a depressive episode, there's like over a 90% chance you're going to require an antidepressant for basically lifelong at that point.
I mean, basically sometimes we just don't make those chemicals that we need to kind of maintain a stable mood. And luckily we have medicines that can, replace that chemicals. It's like diabetes, a person is not making insulin, so you give them insulin to help your body be more efficient. Well, people with depression may not have enough serotonin or norepinephrine or dopamine, which is just another chemical. And luckily we've, developed these medicines that can help them also manage efficiently, It just is, it's not, a lot of people think like mental illness is something separate than your physical body, but it all goes together. All of these systems work in tandem with each other. And if one is off, it can all be off. And so luckily we have these medicines. And we only have a basic understanding, really. I don't want to say that, depression is a serotonin deficiency. It's more complicated than that. But these medicines do demonstrate that there is something off in that pathway, the serotonin pathway, and these medicines can help.
Well, you bring up a good point, like the more meta-analysis and research that's done, it seems like the serotonin theory is obviously not everything, right? Like there's been studies that show there isn't really a big serotonin difference between people who are depressed and that are not depressed. But obviously, the medications do have an effect and work.
And what the serotonin does in your brain. Like I don't think we understand, everybody is different. Their brains work differently. And what serotonin does in my brain, we may have a general idea of what it does. But for a person who's depressed, it might do something different. Or you don't know if that one stressor that you're going through shuts that, hits some gate up there, and, we just don't know.
Yeah.
It's very interesting.
I mean, it is stronger than placebo, right? So I agree. There's sort of other alternate theories that like it can increase like BDNF, which is basically like a brain factor, which can
inflammation,
increase neuronal growth, right? So if you increase even neuronal connections, maybe that sort of can help the individual. So there's some studies or topics about
glutamate.
Glutamate and affecting like even like your gut microbiome. So I mean, I think there's kind of like a conglomerate of things that sort of go into effect that can have an impact on the patient. And that kind of even goes back to like, well, these all kind of originated from like an antibiotic, right? Like, which is interesting, you know?
Yeah.
But medications aren't everything to some degree, right? There's compared to placebo, right? There's like a 15 to 20% increase or improvement in symptoms compared to placebo, which is significant, but it's not 100%. So, I mean, patients are complex. There's so many things that are going on. I mean, for me, when I see a patient and it's like they come in and it's like their spouse cheated on them, they lost their job, their pet died, or there's some major stressor going on in their life. It's like, I really feel for them. I hope the medication will help kind of get them through that moment. But there's like, life is hard,
Yeah, it's just a tool. And a lot of times people come in and they want that medicine that's going to fix everything. And it's like we have to break it down, It is a tool, but it is not everything. Some of this work we have to do ourselves and trying to sort out, how do we manage stress? How do we cope with stress? What are we learning from the stress? Maybe these things that we're going through are there to teach us something about our own character and our own sort of how do we survive in a lot of ways.
Yeah. I think that's why we always recommend therapy.
Always.
I mean, therapy is really where you gain insight and kind of learn your own interpersonal style and kind of even maybe things that have happened to you in the past and how you relate to the world. That, I mean, a medication's not going to bring that kind of awareness.
The yin and the yang, right?
Exactly.
Medicine and therapy. That's all the research shows that that's the best treatment, for depression over the long term.
The two tools in our toolbox that we have. Yeah. Well, when it comes back to medications and antidepressants, I mean, let's maybe give some examples of patients, and I want to hear, T, like what you would prescribe in that moment.
Okay.
So let's say it's like an 85-year-old woman. She's just getting more apathetic. She is forgetful, but it seems to be more related to depression, right? She's losing weight. having trouble with sleep. Like, is there a certain medication that you would use in that instance? Or
yeah. Like it just shifted up into my brain as you're talking. First of all, 85-year-old, right? So we're going to use something that's hopefully not harmful to the older population. I'd probably use mirtazapine.
Yeah.
Or Remeron is the brand name of it. It is a great medicine. It's a little odd, actually, in that it's a tetracyclic antidepressant. It is a medication that if you give lower doses of it, it helps with sleep. One of the side effects of Remeron is that it can cause sedation. So like I was saying earlier, we would tailor this one maybe towards somebody who's not sleeping very well. It also can increase appetite. So somebody who's losing weight and not eating enough, this medicine is great for both of those things. And it also, at higher doses, so lower doses makes you more sleepy. Higher doses start to get into the antidepressant and anti-anxiety effect.
Yeah.
So you can sort of taper it up over time. So you start with a low dose to help people get to sleep, and then over time increase to the more antidepressant dose.
Yeah. Another thing about mirtazapine I thought was interesting is it seems like a lot of alcoholics or substance abuse individuals, like they really kind of favor towards that medication. Mm-hmm. I don't know if it's like because it's really helped restructuring their sleep architecture, or if some of like the antihistaminic properties just like gives them some sense of calming. But yeah, I've noticed that with mirtazapine, and you're right, like any individual that has like weight issues, like they're losing weight or have reduced appetite, we always think of mirtazapine.
Yeah.
Individuals that may be cachectic from like, cancer or just, old age, failure to thrive, like it's something we use a good bit. And I mean, so I think it's one of the better antidepressants,
And then we often use it in conjunction with other antidepressants. So let's say you're on Prozac or Zoloft and you're doing okay, but you're still not sleeping well. We often will just sort of add it on, a low dose of it, to help them with the sleep part, and it can kind of boost the effect of the original antidepressant.
Yeah. Giving another clinical scenario here for you, T, if it's like, let's say a 14-year-old, she...
Lexapro.
Off the bat.
No, go ahead.
Well, I mean, that's fair. What I was going to say is she's depressed, she self-harms, a little emotionally reactive, doing poorly in school, and we'll even throw in she's, oppositional and defiant with her family, like she's, refusing to do her chores.
What would you use? I've got some ideas, but...
For me, so like you mentioned early on, like Lexapro and Prozac are FDA approved in children, just because they were able to get that indication,
right.
But I just find in those kids, like I'll start them on Lexapro or Prozac, they all end up on sertraline. I'm serious. There's something about that anti-anxiety component from the sertraline.
Really?
I've just noticed it. Yeah. So
I get a lot of people complaining of GI side effects with Zoloft and headache more, so I tend to not start with that one. But yeah, and that is that is something that people do talk about with antidepressants. There isn't anything that we can really prescribe that doesn't have a risk of some side effect. We couldn't even prescribe aspirin without some risk of a side effect. So you're always down to what are the risks and the benefits.
Yeah.
So if the benefits outweigh the risk, then you're more likely to try it. But if you're having side effect after side effect after side effect, you really have to consider changing or stopping that medication. But what are some of the common things or things that people most complain about with antidepressants? Have you?
Yeah. So, when it comes to side effects from antidepressants, I always tell all patients, like, the main one is GI side effects, like you mentioned. So there are serotonin receptors in our gut as well. It's everywhere. I mean, even our platelets, right, in our body. You could be potentially have an increase in loose stool. And I always tell patients...
Bloating, feeling.
Yeah, just like feeling unsettled. And that usually always goes away within a week. So I always say stick with the medication because that will improve. Some individuals can have headaches. There's not really many more, right? Are there other
Sexual
things?
side effects.
Oh, yeah. That's a big one.
That's what most people complain of to me, or don't complain because they're either embarrassed to talk about it. So I usually bring it up immediately, like during the thing. So one of the things you might notice is that you may feel less able to achieve an erection or ejaculate, or you may feel numb when you're having sexual intercourse. So that is not affecting your body permanently.
Yeah.
It is something that you bring to the doctor's attention and they can adjust or change for you. But definitely bring it up.
That's a good point. I've even had friends that have been on SSRIs or antidepressants, and they're like, I just had no libido. It just completely killed it. And you're right. It's something that most people are a little bit bashful to talk about.
But it affects their life. You know, that's a pleasurable thing. So if you can't enjoy that and you're already depressed, the last thing you're going to do is take some medicine that makes it worse. So definitely we encourage people to talk about side effects if you're having them. Don't just suffer in silence.
No.
If you're having something, your doctor doesn't want you to be miserable, especially if you're being treated for something like depression. So
well, and there's
talk about
a little bit of research that I saw about the sexual side effect component of SSRIs, and interestingly enough, like sertraline, paroxetine, and fluoxetine, so Zoloft, Paxil, and Prozac, are more likely to cause the sexual side effects. This is like over 30%, whereas Lexapro, escitalopram is a generic, Effexor or venlafaxine, and citalopram, Celexa, are only 10 to 20%. So it's still there, but it's a little bit less, which I thought was interesting.
And I do end up prescribing Celexa for people who are complaining of that more. So that's interesting.
Yeah.
Must have read that in a study somewhere.
Yeah, you retained it somewhere, T.
Yeah.
It's there in the noggin. When you bring up Celexa, I think it's like a little bit of it's a medication that kind of fell out of favor a little bit when Lexapro became more popular because it's considered a cleaner of the two medications. Like it's just an enantiomer of Celexa. But I do think Celexa has its benefits.
We forget about it.
Yeah.
It's not one that we kind of keep, but it's there.
Are there certain times that you like to use Celexa?
The sexual side effects. Sometimes it just sort of comes up in rotation in my mind, like while I'm talking to somebody, if I've been prescribing something like Lexapro or Prozac more often, I'm like, but let's try Celexa this time.
Yeah.
You know, there's not anything that specifically pops out to me about using it being much different than the other ones.
I think just from residency, I remember sometimes we would use it more in like older population if they had some aggression, because I think it is a little bit more sedating, and so I think there can be a lot of studies like sort of focus on Celexa. But I agree, there's like, besides that, there's not maybe necessarily a specific reason to use it. But I do have like this subset of patients that Celexa was it. I don't really know why, but like it was the one that worked for them, you know?
Yeah.
Which is interesting.
I have had that too. What about so we don't use them as much, but there's a category called MAOI inhibitors. Have you had much experience with those?
Well, not directly administering them. I mean, obviously we learned a lot about them. I've always wanted to use this allegedly patch. I really have, for like treatment-resistant depression. It's like on my list of things I want to do. But because they were the older generation of antidepressants and like the potential side effect of like hypertensive crisis and having to watch your diet, it was like they'd kind of fallen out of favor by the time I was like in residency.
Yeah.
Did you ever prescribe them?
Well, yes, back in residency.
Yeah.
Because, you know, for some people, nothing really, I mean, these are people who've had, and we may get into it, but ECT, they've had, you know, all different types of treatments, all different types of antidepressants in different categories, and we go over very clearly what the diet restrictions are, because they are serious. I mean, MAOIs, if you eat cheese or wine or anything sort of aged, you know, you could get into this hypertensive crisis, and it's very serious. So
I think it was like the tyrosine, right?
Yes.
I think. Yeah.
Yes.
Well,
yeah, we did use it.
Did you notice the MAOIs? Like, was there, like, do you feel like were they a little bit more effective?
Again, for some people, it was like the only thing that really helped them. And, you know, they were, in residency, they were sort of, I guess, hyped to be the ones for atypical depression. So people who were depressed, but they slept too much or they ate too much. So it was like sort of the opposite of what you expect, typical vegetative symptoms with depression. So those people tended to do pretty well. And so you're like, well, what about this? What is it about this depression that would make this particular agent work better?
Yeah.
You know, it's always interesting how they come up with why these medicines work.
Yeah. I mean, going back to the selegiline patch, like it's a patch, right? You place it on your skin, so you don't necessarily have to take an oral medication, and it bypasses the liver, which is why you're not supposed to have like those side effects like you're bringing up from the diet.
Yeah.
I'm gonna use it one day. It's gonna happen.
Do it.
I'm gonna use it.
You can come back and tell us how it went.
Exactly.
If we never see the patient again, then we know it worked.
Right? Be like, those patches were it. I just start prescribing them to everybody.
That's right. You get a patch. And you get a patch.
Well, some people we see, I mean, have been on numerous medication trials, and they don't feel like there's never anything that's quite completely effective. And that's hard because you do start running out of options at some point.
It makes me think of the STAR-D trial, which is this classic study that went into looking at what do you do when these medicines don't work? What's the next step? And it was a very meticulous, really, trial where they looked at people all on one particular antidepressant, and then after so many weeks, they added a different antidepressant, or they got to switch to another one. And they just followed these people over, I think, years. And then they looked at all the data to see which combinations, which changes or transitions were more effective, and they found nothing. They didn't find any significant difference between these different agents. So it really didn't give us any information about how to, systematically treat somebody with depression, how to go from one type. So it really is still up to the provider and the clinical situation as to what agents that you use. But what about Wellbutrin? Do you use a lot of Wellbutrin these days?
Yeah, I was thinking that while you were speaking there, actually. So Wellbutrin, I really kind of say for younger, let's say college age or young adults who have more difficulty with energy, motivation, and concentration. Wellbutrin's sort of like a pre-amphetamine, and so it tends to boost energy and help with depression. But it doesn't really do a lot with anxiety because it tends to focus more on increasing norepinephrine and dopamine in the brain. And so, I actually like it a lot. I'll use it a lot as an adjunct even in, let's say, older individuals that have a lot of trouble with energy and maybe apathy. I will say you have to be careful, right? Individuals that have like an eating disorder or seizure history, it can lower seizure threshold, and so that's important to like pay attention to.
Or they're in alcohol withdrawal.
But I mean, it's kind of funny. So my third year in med school, there was this one rotation where literally the attending was like super old school. He was like in his 60s. He was notorious for like failing one student a month. Okay, and he would like almost target someone. And it was an internal med rotation. I have to get there at like 3:30 in the morning. I would stay till like 6, 7 at night. It was so stressful. So before I started that rotation, like I was so nervous about it. I went and saw like a private practice psychiatrist, and I was like, I'm just nervous about this rotation. Like I really want to get through it. And at the end, he actually liked our whole group, and we did a really good job. But I was put on Wellbutrin for that month, and then I stopped afterwards. So I noticed like the first 3-4 days I had this like energy jolt. Yeah. And then eventually my body kind of acclimated to it. And then it kind of felt like I was just taking it, But it did, I did notice the difference, And it's kind of funny that's what he put me on. He's probably like, this med student, like, get him out of here.
Well, sounds like he knew what he was doing.
Yeah,
because it gave you some energy.
Yeah, and it helped because I was waking up so early in the morning. You know, it's kind of funny.
The other thing I worry about sometimes with Wellbutrin is in our patients that may have psychotic symptoms, because it is a little different than the other antidepressants we've been talking about. It increases dopamine, like you said, and so one of the mechanisms for psychosis, one of the theories, is that it's a dopamine problem. And so you give somebody Wellbutrin, boost dopamine, it can increase psychotic symptoms.
Yeah,
I mean, you have to be careful.
That's a really good point. Well, T, I was thinking about maybe playing a little game here called Kiss, Marry, Kill. Okay. So I'm going to name 3 medications, and I want you to tell me which of the 3 would go into each category, okay?
Okay. Kiss, marry, or kill.
Yes. And so maybe the difference between kiss and marry would be...
something you're willing to try but not stick with forever.
Yes, I like that. And then marry would be like, I'll take this for however long. So let's go with Lexapro, sertraline, or another name for it, Zoloft, or Paxil.
Okay. Paxil, I would kiss, because I've heard that it's really great, especially for anxiety, but it has so many potential side effects. I wouldn't want to take it for long term, but I would be willing to try it. What were the other two? Lexapro and Zoloft?
Mm-hmm.
Probably I'd kill Zoloft because of the GI side effects, and I'd marry Lexapro.
Okay.
What about you? Let me give you some three different medicines here. Let's try Selegiline, Prozac, and Remeron.
Ooh, that's good.
Mm-hmm.
Man, I don't want to kill any of them.
They're all good.
They're all good.
In their own way.
Yeah. You know what? I'm going to kill Prozac just because it's a staple.
Yeah.
It's basic. We all know it's there. So
You're basic.
You're basic. We're done with you. I would say kiss Selegiline because I just want to see how it works.
Right.
And then marry
Remeron?
Remeron, yeah.
Okay. Sleeping and eating well forever.
Mm-hmm.
Okay.
It was actually like a meta-analysis done, I think it was like a few years ago now, but kind of went through multiple studies and tried to determine which were the most effective antidepressants. Mm-hmm. And it kind of honed in on 4. I mean, I don't think it was like a huge necessarily difference, but they mentioned like Effexor or venlafaxine. Mm-hmm. They mentioned mirtazapine. Mm-hmm. They mentioned Zoloft or sertraline, and they mentioned Lexapro or escitalopram. Okay. So, yeah, I mean, it's something I've always kind of kept in the back of my mind. Like, those are kind of like 4 contenders, you know? Mm-hmm.
And ones that we really didn't talk about, the SNRIs.
Yeah.
Things like Effexor and Cymbalta. Those are coming around a lot more, I think. Especially Cymbalta, I see that a lot with people who have chronic pain because it's sort of marketed to be helpful for people who have chronic pain issues in addition to being an antidepressant. So I do see that a lot. Effexor, I see, especially after people have failed SSRIs. Mm-hmm. So let's say we've given them Prozac, then Zoloft, then something else, Celexa, and they're just not doing well. Then we go to a different kind of category, which that's what Effexor and Cymbalta are in. Effexor, I feel like, is really effective in a lot of different ways. For some people, it gives them more energy, and other people, because it has the norepinephrine part to it. And for other people, it makes them sleep better for some reason. It's interesting how people are different. But you have to be careful with that one because of the norepinephrine part of it. It can increase your blood pressure.
Yeah.
So people who have hypertension, you have to kind of be careful.
I agree. I've noticed a subset of patients where they didn't really respond to the other antidepressants, and like Effexor was the best for them. And the biggest thing with Effexor I've noticed is like you do have to closely manage it because that the SSRIs can cause withdrawal symptoms, which we can go into, but the SNRIs you really have to be careful. Effexor has like a really short half-life. I think it's one of the shortest of all the antidepressants. And so I've had patients mention things like my whole body feels like it's zapping, or there's
electrical
zaps going down their arms or the back of their head, and it can send people
uncomfortable.
Yeah, I would imagine. Like if you feel like you're constantly sticking your finger in an electric socket.
Yeah.
And I mean, it leads to like emergency room visits. Like I'm sure people get like extensive workups when it just ends up being a withdrawal. But that being said, like you mentioned, it has more, that's where the N comes from in SNRI. It has more norepinephrine effect, and there's increased energy, and it does seem to work pretty well.
It's a nice hybrid between the serotonin and norepinephrine pathways, so you get a little bit more bang for your buck.
Yeah. And the Cymbalta, like you mentioned, is the other medication in that class, and we use it a good bit. Like if chronic pain is there, if migraines are there, I always think about Cymbalta. Cymbalta tends to affect norepinephrine a little bit earlier at lower doses than the Effexor, and so I think that's kind of maybe why it's more of a go-to for chronic pain.
So smart.
Learned it at some point. So, I do like Cymbalta.
Pristique. I don't see that as much, but it is another SNRI that you might see out there.
Yeah, it's newer.
Venlafaxine.
Yeah. There's a lot of medications that are kind of like just a small change in the molecule compared to other former medications. So to me, like Pristique and Effexor are very similar, right? I mean, it's in the name. Venlafaxine, venlafaxine. But again,
citalopram, escitalopram.
Yeah. But you do have patients where they respond to one and not the other. It is kind of an art. I don't know about for you, T, but sometimes like talking to patients, they're like, they just kind of want the right medication right away. And we do the best we can. But it is a little bit sometimes of a process, which can be like frustrating for them.
Especially, from this emergency room standpoint, which is where we are. We're not in a clinic.
Yeah.
So we're not going to be following up necessarily with these people, although we often do.
Yeah.
They'll come right back. But yeah, just trying to explain to people the whole thing. And I feel like that's really the part that we can do the best at, is to give people information and not just give them a prescription and say good luck.
Yeah.
But like explain the process, talk about what to be looking for and what to realistically expect from the medications. That this is not a cure-all. It may help you a great deal, but it may not, do everything that you're expecting it to do. So have a conversation about what they're expecting and what you can deliver, because you may not be able to match those up.
Yeah, no, I know. I wish we could be like, well, here's Prozac and a house, or here's Prozac and
you won the lottery,
$100,000. Then maybe but yeah, I agree. It's sort of a method to help them boost their mood to the point where they are able to engage and become more active.
Just trying to give people hope. Mm-hmm. By the time they come into the emergency room, it's sometimes the worst day of their life.
Yeah,
if they're coming there. Yeah.
Yeah, most people don't just come to the emergency department
to say hey.
Right. Yeah, there's they've really reached a point, and they want to kind of hide that from you to some degree, which is hard. Mm-hmm. I guess T, question: if you had to be on one antidepressant forever, which one would you pick?
Forever? Forever, ever?
Well, maybe not forever, but if you had to take one, which one would you pick?
I don't know. I have tried antidepressants before and had the GI side effects that we're talking about, so I didn't take them for very long.
You're a typical non-compliant patient, aren't you?
Well, I had a discussion with my doctor about the side effects, and we both decided they were not for me. I think, honestly, I would try ECT.
Okay.
I mean, I know that it kind of has a bad rap for some reason, but I have seen...
I like that red herring you threw out. Yeah. Seriously.
I have seen, miracles, really, on the unit. People who have been depressed their whole life. In 3 days, they are up, eating breakfast, the sun is shining, the birds are chirping. They have never felt that before. It is so effective.
I want to vouch for ECT 100%. I mean, there's no medication trials are around 40% effective. ECT is over 80% effective.
Yeah.
There's no medication we have that is as effective as ECT. I think society is fearful.
Yeah, demonized it from One Flew Over the Cuckoo's Nest and all these media images of the padded rooms and it was there were horror stories, I'm sure, back in the day.
But I mean, I performed a lot of ECT in residency.
Yeah,
I mean,
me too.
You give individuals muscle relaxers.
It is not the 50s,
it is so
people.
serene. I mean, they literally the only activity you see is on the monitor as the seizure's occurring, which lasts for about 30 seconds. And then, they wake up, you place a mouth guard just to ensure that there's no harm in any way in case they do have a little bit of mouth clenching. But I mean, it is I hate to say serene, but it's very, very boring to watch, actually.
For those of you who don't know, ECT stands for electroconvulsive therapy, or the shorthand is shock treatment, people used to say back in the day. And it is now performed in in an operating room or a medical suite where you are under anesthesia. So you're asleep. Mm-hmm. The only real risk is if you have cardiac problems or some other reaction to anesthesia in the past. Other potential side effects, you may have some short-term memory loss. So you won't forget who you are, but you might forget what you had for breakfast that day of the treatment. And no sexual side effects, no GI side effect, none of the things that you might experience with medications. Now, some people who get ECT are also on medications too, but ECT itself is so effective, and you don't have to take medications, potentially.
Yeah, I mean, I think because it is a procedure, we often save it for treatment-resistant patients typically because it is so effective. And I understand that. I don't necessarily want to be put to sleep and have a seizure per se, but I mean, the effectiveness of it, and there's just many theories behind why it works, which I can go into to some degree, but really they think it kind of can reset your hypothalamic axis. There's again increased brain growth. There's like a lot of many different reasons. It is very effective, and
so if I had to take something my whole life, that's
that would
probably
be it.
Just a little booster.
Once
a month, a little buzz.
And once you're under maintenance, then you wouldn't need it very long. I guess in some sense, are there other medications that maybe aren't antidepressants that you use as an adjunct or that you like to use for depression?
When I was in residency, they really hyped thyroid hormone.
Okay.
Remember that?
Yeah, that's actually very effective.
Yes.
That we don't
thyroid
often
hormone,
think of.
Right. Thyroid hormone and lithium.
Yeah.
These were things that were really shown to be very effective to add to an antidepressant to help the effectiveness of the antidepressant. And it also had its own qualities. Like lithium is known to protect against suicidal thoughts. So if you're depressed and you have suicidal thoughts and you are, maybe have some trouble sleeping or a little more irritability, lithium might be a good thing to add to their regimen.
Yeah, I kind of feel like lithium should just be in the water, to be honest. But even while you're talking about ECT, there were studies that showed like either lithium or nortriptyline, which is a TCA, can help improve the efficacy and long-term treatment of maintaining your mood. Yeah, I agree. Lithium, I think, is a great medication. Obviously, we kind of reserve it for bipolar or acute mania, but the mood stabilizing property of lithium is not to be ignored.
Yeah, it is a great adjunct if you're looking for things to
I
add.
often kind of look at either Abilify, just because the side effect profile is low. It's actually a second generation antipsychotic, but it's only like a partial dopamine antagonist. And, we do use it sometimes even monotherapy for depression. And Seroquel, quetiapine, which is another second generation antipsychotic. But if there's sleep, there's mood instability, it can be helpful. And I kind of like those too sometimes as an adjunct.
Something else we used to use especially for elderly people who had depression and just didn't have any energy or motivation, we would use a little bit of Ritalin.
Interesting, yeah.
Like a little 5 milligram or 2.5 milligram. In addition to their antidepressant, gave them a little bit more energy and concentration during the day. So that's just another sort of down the list of things.
Yeah.
But there are lots of things that have been tried to work with these antidepressants to get them a little bit more effect.
If you give someone an amphetamine, if you think it does boost their energy, and I mean being older and having maybe the beginning signs of dementia or just some apathy from depression, I mean I do see like a low dose amphetamine being helpful. And something else too in regards to the elderly population is as we get older and our brains age, especially if there's a dementia component, we don't have as many neurons. There's less neural connections. And studies kind of show even depression based from dementia or just depression in the elderly, like antidepressants are a lot less effective. And we think that's because there is a lot less substrate. There's a lot less matter. There's a lot less to work with. So even if you're giving them the medication, it won't be as effective. And it's just like there's just not the neural connections that are there. So something like a little bit of amphetamine may give them that boost, I mean, obviously we have to just worry about increasing dopamine like you mentioned before and making sure they don't become like psychotic or anything. But I mean, if there's no concerns, it's like it greatly improves their quality of life. Like, why not,
Yeah, again, this podcast is mainly meant to just have conversations about these medicines. We're certainly not prescribing or telling people, what they should take. Every case really needs to be looked at, again, individually, what is going to benefit this person.
Absolutely.
And you try to find combinations sometimes. I mean, you always just try to start with one thing, because if you're building something over anything over time, do one thing at a time so you can sort of measure how it does before you add on things. You come in, people are on 16 different medications, and then you're trying to piece together why this person is on this, and start with one thing, see how they do. It's like you're a scientist, basically. You're taking data about how this person is responding, and then you go to the next thing and sort of see how they do. And if you need to come off of the other one or slow it down, you can make adjustments over time. But definitely case by case, you're looking at what's going to help this person's collection of symptoms the most with the arsenal that you have.
Absolutely. And always make sure to talk to your provider about this, because everything is very individualized and case by case. But we just wanted to talk about, have a little general conversation about it, because, I don't know, maybe people will find it interesting.
These are some of the most common things that we prescribe for anxiety and depression. Any other interesting things happen to you this week?
Well, I guess it's kind of funny. So I've been in therapy now for like a few sessions, and talking about things that are going on in my life, and then I brought up how even as a provider, like sometimes if you have a little more going on in your life, you can tell like even your own mood like in the room can be affected to some degree. And so I made a like offhand joke like to my therapist. I was like, it's like I'm going through some stuff right now, and sometimes it's just hard to listen to someone crying about their cat dying. Mm-hmm. And literally 2 hours later, I go to work, and like the first person I saw was like sobbing about losing their cat, and I was like, am I psychic?
Full circle. Right. Did I telepathically bring this person in here?
Did I manifest this? But it was just kind of, in the moment, it was like really funny, actually. I was like,
Did you laugh?
No. I mean, no, actually, like, because I have 2 cats, I was like, oh,
right.
But I was like, just like, that's really funny that's what happened,
Yeah.
How about you?
No, nothing really. I mean, this was like the full moon week, and so things were really, really, and people don't, I think we're going to talk about this later on, but there really is some kind of connection between the phases of the moon and mental health. I think we're going to look more into that. But it was very, very challenging this week in the emergency room.
Yeah, it was a very busy week for us.
And not just more people. Mm-hmm. Like the actual cases themselves were so strange.
Yeah.
Just things that people are dealing with. And
I know. I mean, that could be another topic we talk about, is because we've taltalked about that, like maybe having shorter episodes about different things that are going on,
hot
like
topics.
Culturally, hot topics. Hot topics.
Trend alert.
Right. But I agree, like, with the way society is right now, you almost see, like, people are struggling, you know? And so we're doing what we can.
All over the world.
Yeah. So...
Well, on that note.
Well, yeah, can we let's end on, like, a positive note. My cats are still alive.
Yay!
So there's that.
And it's the weekend.
It's the weekend.
And I actually have this weekend off, which
nice.
I'm excited. Yes.
Good. Yes. Go out there and...
I think I'm going to grill, get a nice juicy steak.
Ooh, that sounds amazing.
Yeah, and some corn on the cob. Wouldn't that be good? Some potatoes.
Ooh, one other quick thing. When I was looking at information, so a high corn diet actually affects the CYP2D6 in the liver, which is where you metabolize it's an enzyme that you metabolize antidepressants. And a high corn diet actually slows down that metabolism by like 60%.
Oh. Well, good thing I'm not on any CYP2D6 meds right now, but that is good to know.
Right?
Yeah.
I was like, so if you...
I mean, just in general, these enzymes are affected by food,
everything,
by
smoking,
other medicines, smoking, alcohol, all these things.
So, for sure. But yeah, so that's kind of funny. So just enjoy your quarantine.
I will. See y'all next time.
Bye.